Ladies and gentlemen, welcome everyone. Thank you for joining us for today's webinar brought to you by nView Health. My name is Leisha Richardson and I will be the host for today's call. If you have any technical questions or need any assistance during the presentation, please send a chat to me in your chat window and I will respond accordingly. If you have any questions about the content of today's presentation, please type them into the question and answer box in your control panel and send them to all panelists. We will address questions at the end of the webinar as time permits. At this time, I would like to turn the program over to your moderator for today, Chris Watson, Chief Marketing Officer for nView Health. Thank you, Chris.
Thank you, Leisha, and welcome everybody to today's webinar. Our title is Modern Technology, how modern technology can help health systems better identify and address behavioral health issues. Now let's meet our speaker for the day, Dr. Thomas Young. So if we could advance to the next slide, please. All right, Tom here is joining us today. He has over 40 years of medical practice experience. He's also the co-founder of nView Health, who is sponsoring our content today. Tom has been a CMO, Chief Medical Officer, for many different medical organizations and is also a serial entrepreneur. We're very blessed to have him and all of his years of experience commenting on the topic of modern technology today. So Tom, I'll go ahead and turn it over to you.
Thank you, Chris. I want to thank all of you for attending and see if we can together learn some things this afternoon and be able to share some ideas. What we see as the top challenges for health systems in the behavioral health space are really the fact that there's an increasing prevalence of behavioral health issues in our society, rising suicide rates, and that all of these things are impacting not only individual providers, but health systems across the globe. Integrating behavioral health into the physical healthcare system of the United States is one of the newest and most challenging things that we've seen in healthcare in the recent past. We're plagued by misdiagnosis and non-diagnosis of severely impacting health systems' ability to meet effectively in value-based care contracts. When you don't get the right diagnosis, you don't make the diagnosis, you increase costs and you increase risk to the individual patient. Also, the lack of evidence-based, clinically validated screening and assessment tools has made it a challenge for clinicians across the board to both standardize their behavioral health assessments and to create organizational networks of providers that are working off the same technology and the same information. Who is nView Health? nView Health is using tools that have been used for more than 25 years around the world in multiple languages, currently translated into over 160 languages, used in almost every country on the globe over the past 25 plus years. These have been clinically validated and peer-reviewed multiple times. Our suite of services has been cited in studies and clinical use in 17,000 plus articles. It's been a team of people that have done this over the years, and recently we have launched these digital version of what has been a paper-based tool to be able to provide this service to individual practitioners and systems across the globe. We provide these now in multiple countries and are expanding that as we speak. Our tools are based on basic studies of 7 to 24 plus pediatric disorders that can be screened for and then interviewed for. I want to use a couple of use cases today to be able to really identify the individual places that this can be used. If we take, for example, an ER, and in ERs today, we have a number of issues that relate to being busy, and increasingly the site of admissions for the ER is obviously to treat and get a correct disposition and get that in a timely fashion to meet the needs of a busy ER. They need consistency. They need more standardized ways of documenting behavioral issues, and they need this to not only improve the outcome but to decrease the risk associated with these types of diagnoses. They need data-driven decisions that will allow them to structure an interview, capture trends, and support their clinical decision-making on a day in and day out basis. From 2001 to 2016, ED visit rates for non-fatal and self-harm diagnoses increased 42% among people aged 10 and over. We're seeing an increased use of ER and self-harm in younger age children. It really starts with being able to identify the individual patient and be able to have that patient start a process. The process starts with screening. And once that screening is done, interviewing, you should be able to create interviews that can be done in a number of ways. First is by tablet, given to the patient as part of an initial screening in the ED for all patients or specifically for patients at risk. And then providing a focus-based psychiatric interview tool that allows you to decide what you need to look at and what you want to look at in more depth. You can simply start an interview by having a person in the ED provide a question and answer process with the individual patient, or the individual patient can actually do this very quickly on a tablet. So we start with a series of questions, very simple, can be touch-based, allows the physician to get a rapid answer, to move through multiple different types of questions, to really resonate with the patient and end up in a diagnostic position. So you need to be able to provide the information that allows the physician to understand what diagnostic statistical groups of DSM-5 the individual patient meets the criteria for. Once that's presented to the individual provider, then they have the ability to decide, based upon their information with the patient, based upon seeing the patient, what they believe is the underlying basic diagnosis. So we make that diagnosis, and then that presents a patient that has now been evaluated, has a specific diagnosis, and can lead down a path of treatment, can lead down a diagnostic opportunity for that individual patient in the ED. Using their own protocols then, this can enhance and speed the ability of the ED physician and staff to determine the appropriate disposition. Does this patient meet criteria initially for admission? And if so, how do I start that process in the individual facility? Secondarily, if this is a patient that has perhaps a self-harm diagnosis, using particularly specified tools for suicidality assessment, you can further assess the risk of this patient and allow you to make a diagnosis and disposition that can perhaps send them home or to another outside facility, depending upon the level of suicidality and the level of potential self-harm. So moving to a different use case, primary care. 80% of all diagnoses of mental health disorders in this country are made by primary care physicians. 85% of all the prescriptions written in this country for psychotropic drugs are provided through primary care. This may be internal medicine, it may be family medicine, it may be pediatrics, but these are the frontline people that are making these diagnoses. Primary care has a particular need to have available to it better evidence-based outcomes. They need the ability to quickly identify patients, quickly screen patients. They need to be able to have a complete solution that allows them to screen appropriately based upon age, screen for multiple disorders simultaneously, and the ability then to move to the next step, which is an interview that allows them to make an accurate diagnosis. The single solution is the approach to do this. Currently, we have a system in this country that has people using multiple different screeners, screening for various different levels of symptomatology. And I emphasize symptomatology because it really is symptoms that the current screeners are looking at. So for example, if we use a GAD-7, what we understand about the GAD-7 is it's looking for symptoms of anxiety and anxiety-related symptomatology. It is not really presenting opportunity for the provider to make an accurate diagnosis of the type of anxiety, of the correct diagnostic grouping for anxiety. Same thing is true for depression. We see the same thing in substance use disorders. So in essence, what happens to get a good behavioral health screen is primary care providers are having to present multiple screening tools. Once those multiple screening tools are presented back, they do not have the attached tools to then complete a diagnostic regimen that allows that provider to accurately provide the information necessary for treatment. They need completeness in that solution. They also need evidence-based support. Primary care providers do not have all the necessary psychiatric training, nor do they have access to psychiatrists in a reasonable amount of time in many places throughout the country. They need the ability to have accurate evidence-based support that's psychiatrically validated to allow them to improve their accuracy of diagnosis, to improve the speed with which they are able to refer and deliver the correct therapy, or the appropriate opportunity to provide therapy in their practice to their patients. So taking, for example, what we did in the ER with the patient, if we start with the patient, one of the things we need to be able to do is to be able to look at all of the things presented about a patient simultaneously in a single location. We've made the diagnosis, we've decided on that, and now we begin to see all the information about the individual patient in a single location. That data is collected and is now available for study and follow-up. We also need to be able to look across the spectrum of patients. This is a perfect example where we have the ability to look into a patient population and begin to see the probability of suicidality, people who might be at risk in the practice, no matter the size of the practice. We need systems that can aggregate data, can put it in front of us using artificial intelligence and correct diagnostic algorithms to tell us who's at risk. We have to be able to see that quickly. We have to be able to look into that individual patient. We have to be able to aggregate patients across diagnoses. We have to be able to know in our practices, what do I need to know about individual patients? And in doing that, we need to be able to track and monitor patients. In tracking and monitoring patients, we improve the ability of an individual provider to really focus on value-based outcomes. So in this example, we're going to track this patient over time for his level of post-traumatic stress disorder. Not only will we be able to see if his medications, if that's part of the treatment regimen, are working, but any and all other types of treatment that may be going on, because this is across the board a measure for his level of PTSD. We confirm that, we decide to do it weekly. We can now execute that out to the patient either in a text format, in an email-based format, so that patients can be met at their own location. We can follow them over time, and they can answer and respond to the system in their own particular manner as they choose. So what happens is we then have a scheduled follow-up with the patient. We can begin to see what is his first score, and then characteristically over time, we can watch and see how many times we've sent it and begin to get a graphic input of how is this patient doing. Is our treatment assisting this patient in improving his or her outcome, particularly as it relates to their individual disorder? We can certainly track multiple disorders. We can track symptomatology, such as if the real problem for this individual patient, whether it's a child or an adult, and these tools must be available to children. You have to be able to look from 6 and up at behavioral health disorders. We're seeing more and more children more and more suicide issues, more and more depression issues falling down into the 10-year-old bracket. So these tools have to cut across age and have to be able to allow us to see what's going on over time with an individual patient. So keys for the new technology have to be able to define and screen accurately for multiple disorders in the same time frame. We can no longer have and no follow-up interview tools available to our physician and practicing provider population. We need to be able to aggregate the data. We need to be able to see how patients are doing. We need to be able to track. We need to be able to track and follow populations all the way from age 6 up with validated, clinically supportable tools. So we really need to be able to provide consistent, evidence-based data. We have to do efficient screening. We have to effectively provide psychiatric diagnostic group level information. We know that patients and providers can benefit from enhanced diagnosis, and improving accuracy can reduce the time in this country from onset of first symptom to accurate diagnosis. We need screens and assessments that create billable events that can drive new revenue streams to allow providers to effectively provide these tools. And these data-driven insights that we have need to lead to better outcomes. They need to lead to better quality scores. They need to drive the opportunity for providers and IDNs and large networks to get into the new era of value-based payments. All of these things have to be met in a technological support service for behavioral health. Summary, we need highly validated tools. We need tools that have been around and have stood not only the test of time and peer review, but have stood the test of research and research around the world. Many tools that are out there today have limited validation against multiple populations. Population bases are different, and tools need to be validated against multiple population bases so that we don't get inherent bias in our tools that don't drive evidence-based outcomes. They have to be easy to use. This has to be something that can be done by any provider, by any practitioner, in any group. It has to be easy to train people to provide these tools. It has to incorporate into existing workflows, and that means it has to be able to incorporate easily into any EHR so that the data that's obtained from these tools across both the physical and behavioral health spectrum for an organization. It needs to be reimbursable. We cannot expect providers to take on increased workloads without providing reasonable reimbursement for that process. We have to provide value to payers. Payers have to be able to see the value of a particular set of tools, services, or activities. Without value, payers are going to be reticent to participate with us in this improvement in care and behavioral health. And we also need to improve patient outcomes. Right now, today, less than half of the people with a diagnosis of depression in this country receive any treatment whatsoever. A lot of that has to do with improving diagnosis, improving access to accurate tools, and improving access to accurate therapeutic interventions. So I think if we summarize this all, what I think the importance of new advanced tools in behavioral health is the ability to enable all providers at all levels in all phases of the medical care spectrum to be able to access accurate information and provide improved outcomes, whether this is in pediatrics, whether this is in obstetrics and gynecology at the postpartum depression level, whether this is in cancer as we're looking at people's behavioral and emotional responses, whether this is in the dialysis sector where depression and behavioral health disorders are highly relevant to outcome and long-term survival and long-term good life. So there are multiple areas where this can improve patient outcomes, and we really need to look to those at this point in time to be able to provide these tools. I think with that, we'll stop and talk about some questions. Be happy to answer and follow up with you. So I'll turn it back to you, Chris, for the Q&A.
Yeah. Awesome. Thank you very much, Tom. Great information. I appreciate you sharing that. We are getting some questions. I'll try to group them for time's sake into categories. And I'd also like to introduce, we're going to be joined by nView's Chief Product Officer, Maurice Rosenbaum, who is going to come in and help support us through the Q&A section. So our first group of questions, great. Our first group of questions really comes around, you talked about speed. You referenced the need for physicians, whether it's in the ER or the primary care, pretty much any setting, to be able to get to the diagnosis or get the information they need quickly. So can you speak to the average time it takes for patients to complete the m.i.n.i?
Certainly. The screener portion of this particular system can take anywhere from 2 to 3 minutes. It needs to be able to be delivered to the individual patient wherever you meet them. Are you meeting them in the office on a tablet-based screener, which can take 2 minutes? Are you sending this screener out by text or email to an individual patient? It depends upon where you meet the patient as to how they get the screener. Screener takes 2 to 3 minutes. The subsequent follow-up diagnostic tool that assists providers in making the correct diagnosis can take anywhere from 5 to 12 minutes, depending upon the number of diagnostic statistical group entities the patient may have provided positive answers for. It does not take a long period of time. Probably the longest we see is about 15 to 18 minutes.
Okay, great. You also spoke about the reimbursable events that occur. So if you could speak to the codes, I guess, the billable codes, and help us understand a little bit more about how the nView solution does support a new revenue stream for physicians who use it.
Currently, in both Medicare, most Medicaids, and most private payers in the country, there are codes that are associated with behavioral health screening. In most cases, people are allowed to bill 4 96127 codes on an initial visit. This is to accommodate the fact that people have been using multiple screening tools as opposed to one single isolated screening tool. The nView screening tool is broken into 4 segments that encompass 17 adult behavioral groups and 24 child behavioral groups. The monitors or follow-up tools, which can be used no more than daily according to the CPT code, or can be billed once a day for follow-up, say for a patient that you're tracking very closely. Used for clinics around the country to find out how patients are doing between particular interviews or between treatment sessions, no matter what the type of treatment, whether that might be TMS, ketamine, CBT, or whatever the treatment protocol. The codes for E&M codes, 96712 and 96791 and 96792 can be added to most physician, nurse practitioner, or other provider coding sets, because what's required for those higher level codes is the ability to document a psychiatric interview. The nView suite of tools gives you the documentation for having completed that psychiatric interview and allows you then to bill for those higher level codes.
Great, thank you. All right, we do have a question coming in around the customization of the comprehensive interview. So Maurice, maybe you can help us understand if the sections of the interview can be customized at all.
Yes, thank you, Chris. That's a good question. And yes, we do have full customization of the different modules, sections of questions that we can do. We can vary that by specialty if need be. So we're glad to make that, that modification.
Excellent. Tom, do you want to add anything to that?
Yeah, I think it's important to understand, particularly in the pediatric space, we break down sort of the process of interviews and diagnostic things into age groups, 6 to 8, 9 to 12, and 13 to 17. And it's in changing wording, groups of potential diagnostic entities scaled for the right age. That is one of the ways that we can customize. Secondarily, particularly for places like the ER, where the ER will be predominantly interested in depression, suicidality, bipolar disease, anxiety, psychosis, and in some areas PTSD. We can customize both the screener and the interview to facilitate the needs in a particular environment within the healthcare system.
Okay, it sounds very flexible, yes. Okay, here's another one, Maurice, that I think you could probably take the lead on. Does the nView system integrate with my EMR system?
Number of different ways of integrating either the results or what we call the ADT patient information and bringing that in to our system and then sending an output back out. So we do have a lot of flexibility when it comes to our integration. We have a full set of APIs as well with documentation on our APIs. So we're glad to discuss integration with various clinics of any size.
Excellent. Okay. I think our last question, it's fairly straightforward, so I'll leave that up to you, Dr. Young, or to Maurice, is about securing the data and is the system HIPAA compliant? And then I think we're about out of time after that.
Yes, the system is fully HIPAA compliant down to how it manages passwords, how it manages the data storage, and how it's encrypted both in transfer and at rest. So yes, we need HIPAA compliance standards. And because nView is a worldwide provider of behavioral health data and assessments, we have to be compliant with multiple individual countries around the world and their security systems as well. Maurice, do you have anything you'd like to add?
No, I think that really sums it up nicely. Thank you.
Well, thank you, Chris. We appreciate the opportunity, and I thank you all for your time. Certainly, if you have questions, feel free to give us a call, contact me directly if you wish. We would be more than happy to follow up with you. Thank you for the opportunity to share your time with us, and we appreciate it.
All right, thank you. So Operator Alicia, is there anything else you need to add before we wrap up today?
No, I just want to let everyone know that a recording will be made available of this webinar today. So look for that in your inbox shortly. Thank you and have a wonderful day.
Thank you.